When a patient contracts undulant fever, the clinical manifestation of brucellosis, they are facing a destructive, long-lasting systemic infection. The pathogen spreads through the bloodstream to seed itself into the skeletal system and deep tissue beds, causing months of debilitating fever and organ damage. This comparison chart highlights the clinical paradox of the disease. While we expect a raging systemic infection to trigger high white blood cell counts and extreme inflammatory markers like ESR and CRP, the actual laboratory results for brucellosis frequently show normal or even low values for all three. A closer look at the hematological differential reveals a specific diagnostic clue: relative lymphocytosis. The typically mobilized neutrophils are notably absent. Brucella survives by functioning as a stealth pathogen. It avoids triggering the innate immune system's sensors, allowing it to infiltrate host cells without being detected. This passive absorption into the host cell occurs smoothly, bypassing the chemical alarms that usually signal a bacterial breach. These unremarkable laboratory reports serve as the first direct evidence of a specific intracellular survival strategy. Once inside the body, Brucella targets the macrophage, the primary cell of the innate immune system responsible for identifying and destroying pathogens. Survival inside this hostile cell depends on the unique molecular structure of the bacterium's smooth lipopolysaccharide, or LPS. This molecular structure features an unusual O-chain and lipid core configuration. Unlike most gram-negative bacteria, this specific LPS possesses exceptionally low endotoxin activity. Because of its low endotoxicity, the smooth LPS suppresses the host's early protective TNF-alpha response, preventing the immune system from mounting an effective initial defense. After ingestion, the pathogen deploys its second survival mechanism, the type 4 secretion system, also known as VIR. The VIR system actively reroutes the vacuole containing the brucella, moving it through the cell to avoid fusion with destructive lysosomes. The vacuole eventually fuses with compartments derived from the host's endoplasmic reticulum. Within this sanctuary, the bacteria can safely begin replication. Species behavior differs at this stage. Brucella suis requires the low intracellular pH to activate this system, while Brucella abortus activates it outside the cell. This establishment of a protected sanctuary in the endoplasmic reticulum explains why brucellosis causes chronic granulomas and remains so difficult to treat with standard antibiotics. From the initial draining lymph nodes, the pathogen uses circulating macrophages as transport to reach the bloodstream, eventually seeding the reticuloendothelial and musculoskeletal systems. This pattern of infection creates the classic undulating fever, where patients experience weeks of high temperatures, followed by afebrile periods and subsequent relapses. Clinicians look for three characteristic presentations: a typhoid-like febrile illness, acute monoarthritis of the hip or knee in children, or persistent fever and lower back pain in older men. Roughly 40% of cases involve the musculoskeletal system, making it the most common focal manifestation of the disease. This spinal X-ray illustrates a diagnostic hallmark of the disease. Brucella vertebral osteomyelitis typically begins as an anterior erosion of the superior endplate of the lumbar or thoracic vertebrae. This focal presentation helps distinguish brucellosis from tuberculosis, as Brucella rarely causes the complete vertebral destruction or spinal cord impingement seen in TB. In cases of neurobrucellosis, the CSF profile shows lymphocytosis, low glucose, and elevated adenosine deaminase. These findings exactly mimic the profile of tuberculosis meningitis. These diverse symptoms are unified by the pathogen's ability to use macrophages as a vehicle to reach deep tissue beds, where it triggers non-caseating granulomatous responses. In endemic areas, the standard agglutination test, or SAT, remains the primary tool for serologic diagnosis. The SAT works by detecting antibodies that respond specifically to the O-chain of the smooth LPS found on most Brucella species. A diagnostic titer of 1 to 320 or higher is standard for confirming an acute case in endemic regions. However, this molecular target creates a significant diagnostic trap. Rough strains, including Brucella canis and the RB51 vaccine strain, physically lack this O-chain. Because there is no O chain present, the standard SAT antibodies find no binding site, resulting in a false negative despite a symptomatic infection. A second trap is the IgG timeline. After successful cure, IgG levels can remain in the diagnostic range for over 2 years. As this illustrates, symptoms resolve while IgG remains elevated. This makes serology unreliable for relapses. Clinicians must monitor clinical status. A failure to account for the molecular structure of the infecting strain will lead to missing an active destructive infection. Standard beta-lactam antibiotics fail to treat brucellosis because they cannot penetrate the acidic environment of the intracellular vacuoles where the bacteria hide. Effective management of the disease requires a minimum of 6 weeks of dual therapy. Using a single drug almost always leads to a relapse. This table compares the 2 primary regimens. The gold standard, using streptomycin for 2 to 3 weeks alongside 6 weeks of doxycycline, results in a low relapse rate of 5 to 10%. The WHO alternative, which uses rifampin instead of streptomycin, is easier to administer but suffers from real-world relapse rates exceeding 20%. This high failure rate is caused by a specific pharmacokinetic drug-to-drug interaction between rifampin and doxycycline. Rifampin accelerates the clearance of doxycycline in the body, lowering its systemic concentration and allowing the bacteria to survive the 6-week treatment period. Treatment must be modified for children and pregnant women by swapping doxycycline for TMP-SMX. For occupational exposures, standard protocols recommend a 3-week course of rifampin and doxycycline. However, because the RB51 vaccine strain is intrinsically resistant to rifampin, exposed individuals must be treated with doxycycline and TMP-SMX. Successful treatment requires precise pharmacokinetic management to ensure lethal drug concentrations reach the pathogen inside the macrophage. Every clinical outlier in brucellosis traces back to the pathogen's primary strategy, hijacking the host macrophage's endoplasmic reticulum. The low endotoxin structure of the bacterial coating explains the lack of standard inflammatory markers during initial blood work. The presence or absence of the O-chain molecule determines whether standard serological tests will successfully identify the infection. The acidic intracellular environment necessitates the use of prolonged dual-agent drug regimens that can maintain therapeutic levels inside the cell. This underlying biological reality accounts for every single outlier we see in the pathogen's complex clinical and diagnostic profile. Managing brucellosis depends on recognizing that the pathogen's unique internal mechanics dictate every clinical and pharmacological exception.